Hi, this is Complex Disease Management Hour 3, and this will cover basic anatomy of the thorax through the additional facts slide. So essentially, bed rest in relation to mechanics of breathing, and then the last slide is additional facts. We will not go beyond go into chest assessment. Sorry, that's my husband's cell phone. The first slide, you might want to turn the page and look at this. Learn how this works. You might want to look at this slide as we discuss that. The first, the ribs, there are 12 sets. The first 7 are true ribs and insert into the sternum, and they insert into the sternum and the vertebral column, so they're more stable. Ribs 8 through 10 attached by cartilage of another segment of the ribs, and ribs 11 and 12 are called floating ribs. The sternal angle is even with the second rib and the first bifurcation of the bronchi. So we're talking about the the lungs, the soft tissue. The vertebral column provides posterior support. Without the support in the back, there wouldn't be any anterior mobility. So the rotation of the trunk. Without that posterior support of the vertebral column, there would not be anterior mobility. On the next slide, the diaphragm is the primary muscle of inspiration. It provides 75 to 80% of normal inspiration. It contributes it contributes 2/3 of the tidal volume. And the definition of tidal volume, tidal sounds like total, and that you can think of that synonym if you want to. It's the air that's inhaled and exhaled with each breath at resting volumes. So that is tidal volume. So the diaphragm contributes 2/3 of that effort for tidal volume in sit to stand, and 3/4 of that volume in supine. It has no stability. It has no bony stability, so it relies on the intercostals and abdominals for support. So the relevance of that is if the abdominals are weak, flabby, overstretched with obesity, the person's going to have difficulty using the diaphragm as their primary muscle of inspiration. Passive inspiration is concentric. It's a concentric contraction of the abdominals. Forced expiration is an eccentric contraction of the diaphragm. People who rarely use their diaphragm are at a significant disadvantage for inspiration. They rely on accessory muscles of breathing, which we'll talk about in a minute. The external, some other muscles that assist in inspiration are the external intercostals. And a way you can think of how these muscles are arranged between the ribs, they call them the front pocket muscles. They run between the ribs. Here I'm demonstrating with my hands, but if you take your hands and put them along your ribs, I don't know if I can change this, change the orientation of this. If you take your hands and orient them along your ribs this way, that's how the external intercostals are oriented between the ribs, front pocket muscles. They're angled down and in toward the belly button. Their contraction, I'll do this again, their contraction, when they contract, it draws the ribs up and out so that it results in increased volume of the thoracic cavity. So that is another muscle of inspiration. So you got the diaphragm and the external intercostals. And those are shown on a diagram on the back. Well, in my book, on the back of that page. Now then you've got the accessory muscles of inspiration, and these should not be used in normal people except like after you run, and you'll see marathon runners marathon runners, or after you've done a lot of heavy aerobic work, then these are the sternocleidomastoid, the trapezius. You get into the scalenes, the pectoral muscles, even anything that's connected to the rib cage, the serratus anterior, the erector spinae, even to pull the rib cage up and out. Anything that's going to give the lungs more room to expand. So as you see in that slide, the sternocleidomastoid, the scalenes, the pectoral muscles, the trapezoid, the erector spinae, the serratus anterior. Those are the accessory muscles of breathing. And those in a normal person should only be called into action with severe aerobic activity. When it's abnormal is if somebody uses those at resting, when they're sitting in their chair, sitting on the side of the bed, or with minimal exertion. What you might have a patient do when somebody has used these chronically, these accessory muscles of breathing, they may have gotten to the point they don't even realize that they use them anymore. So you might sit them in front of a mirror and ask them to watch themselves breathe, and they'll point out to them, do you see you use these neck muscles, which the sternocleidomastoid of course pulls up on the clavicle to raise the rib cage, and point out to them how much they use those muscles. It's exhausting, and they burn a lot of calories, exhaust themselves using those muscles to breathe. I also found a source that talked about even more. That slide lists some of the accessory muscles of breathing, but somebody who is extremely short of breath, has severe COPD, they may even use such muscles, and you don't have to memorize these, but just think of the muscles that somebody, and now I just used accessory muscles of breathing to take a deep breath. They may even use their iliocostalis lumborum, quadratus lumborum, transversus thoracis, subclavius. Do you notice that those are the muscles, postural muscles? So some things to consider if somebody is in late stages of COPD, emphysema, bronchiectasis, other pulmonary diseases, fibrosis. They may have to depend on accessory muscles, so you may need to strengthen some of these accessory muscles. And think about, okay, he's still not getting enough thoracic expansion with use of the sternocleidomastoids. What else can I do? So, okay, I can strengthen the rhomboids, I can strengthen the upper trap, I can strengthen the mid trap, the quadratus lumborum, the erector spinae, go into the compensatory model. What else can we do for this man to ease his breathing, since the diaphragm may be shot because he's got all this obese abdomen, or it's overstretched, or for whatever reason. What else can we do for this man? Got off on a tangent there. Okay, but the expiration should be a passive event. There should be no muscles. Normally, there should be no muscles involved in expiration. The abdominal muscles participate in forced expiration in the normal person. They force the diaphragm back into a resting position. They keep the abdominal viscera in position. Another muscle that participates in forced exhalation are the internal intercostals, and I'm going to show you the arrangement of those in the rib cage. They're called the back pocket muscles. I can't do it with my hands, but their arrangement in the rib cage are front to back. So their alignment is in this direction between the ribs, and when they contract, their action is to draw the rib cage down and in to push the abdominal contents in the lungs in and down. To test the strength of the abdominal muscles, and in my handbook, the the testing chart is not on the next page. So I'm going to show you. Look for this chart in the next few pages. Oops. See if you can find this manual muscle test chart in the next few pages. Okay. It is arranged from the highest grade 5 down to 1. And it doesn't make the most sense to me to start with the highest grade, because usually our patients won't have 5/5 strength. And speech therapists can check abdominal muscle strength as well, because speech therapists will need to know if patients have sufficient breath support for different functions to be able to breathe and eat at the same time. If sufficient breath support for adequate voicing of their for communication. So a 1/5 strength, 5 being what we call normal strength. 1/5 is a palpable contraction with lifting their head. So they're laying in their bed, laying flat on their back in their bed. Let me fix this camera. Okay. So 1/5 strength is a palpable contraction when they lift their head or attempt to lift their head off their pillow. So you're putting your hand. I'll show you. You're putting your hand over where their diaphragm, where their abdominal muscles attached to their ribs. So you're going to just lay your hand here, and they're going to attempt to raise their head off the pillow. Their head's not going to raise, but you're going to feel those muscles tighten. Another thing you can do is if they're thin enough, you can try to put your hand under their last rib, and when they attempt to raise their head off the pillow, the muscle will contract and it'll force your finger out from under their rib. So those are two ways you can check for 1/5 strength. 2/5 strength is with their arms beside their body, so just laying down with their arms laying down beside their hips or whatever. They can raise their head off the pillow. Their head will come up off the pillow. 3/5, they can reach past their knees, so their feet are sitting on the bed. So their knees are bent, their hips are bent, and their feet are sitting on the bed. We call that hook lying position. So when they reach up toward their knees, they can reach past their knees. That's 3/5 strength of their abdominals. 4/5 strength is they lay their hands across their chest this way, and they can raise their shoulder blades off of the surface. So they can get their head and their shoulder blades off the surface. 5/5 strength is they can put their hands either on top of their forehead or behind their head. Now you're not looking for them to pick up their head with their hands. We're just wanting to get their arms up over their head for the weight. Like a seesaw, you're trying to get the weight up here. So with their hands behind their head, they can get their shoulder blades up off of the bed. So that's how to grade abdominal strength. Excuse me for moving this around. That's how to grade abdominal strength. So all three disciplines have a need to know how to grade abdominal strength. Put that back in my manual here. Okay. So a summary of the anatomy of muscles of respiration. In quiet breathing, inspiration is accomplished with the diaphragm and the external intercostals. Expiration should be passive. It requires no action of the muscles to exhale. Forced breathing, forced inspiration would be the diaphragm and the accessory muscles of inspiration, being the sternocleidomastoid, the scalenes, the upper trap, the could be the rhomboids, the quadratus lumborum, the intercostalis transversus lumborum, the serratus anterior. What have I left out? I say the pectorals. Could be the latissimus, erector spinae, subclavius, the upper trap. I'm sorry, pec major and minor. Basically all the muscles of the upper back and the muscles that attach on the side of the ribs, anything that will pull the ribs up and out. So postural muscles. Forced breathing. Oh, so I'm sorry, we just forced inspiration, those. And then forced expiration will be the abdominals and the internal intercostals. And there it says some diaphragm. That is true. With an eccentric contraction of the diaphragm, you will have forced exhalation. Okay, the next slide we're going to the airways. The upper airways consist just of the nose and the pharynx and larynx. So that's what we're talking about when we talk about the upper airways. The nose helps humidify and cleanse the air. So mouth breathers are at risk for dehydration and dryness. The pharynx and larynx consists of the glottis and the vocal folds. There's one muscle that abducts the vocal folds and is vital in respiration. God must have known what he was doing to protect our lower airways and prevent aspiration, because there are 8 muscles that perform that function to adduct the folds. The larynx is between the trachea and the laryngopharynx and consists of cords and folds. And they are the excuse me, I needed to say something about the vocal folds. The vocal folds are the last protective mechanism that the body has for airway protection. When a person swallows, there has to be a coordination of stopping breathing by closing the vocal folds and coordination of the swallowing mechanism. A person with a chronic respiratory disease like COPD can fatigue easily during eating because they can't tolerate the brief holding of their breath that they have to do during a swallow. So the swallow respiration coordination becomes out of sync, and then they're at very high risk for aspiration. And an example of that in a normal person is when we're all sitting around as a group talking and laughing and trying to eat at the same time, and you try to talk with your mouth full and you get choked up on some food. How that has happened is because your breathing, swallowing, coordination has become out of sync and you've aspirated a little bit. Well, that's what is happening to people with COPD much more frequently, because they can't synchronize that well, because they can't hold their breath for that second it takes to swallow. Another point to make is if you think of the vocal folds as a bottle top, in order to control breathing during a transfer from stand to sit, you might have the person count aloud or talk while they sit down, so that they can control the burst of air that comes out through their vocal folds, instead of it just going instead of the air just being expulsed as they sit down. So you might have them 1, 2, 3, 4, 5 as they sit down or speak, so that they just don't plop. As our PT and OT say, no, don't plop. The same thing as just this burst of air coming out through their vocal cords. So that kind of talks about those last 2 points. Control the larynx. The larynx is between the trachea and laryngopharynx and consists of cords and folds, and they control the airflow and help increase the intrathoracic pressure by staying closed for a cough. So when we are working with somebody on coughing, if they have weakness of these vocal folds, they're not going to be able to create pressure for that. So we may need to get the speech pathologist involved when we are working with patients to be able to create an effective cough if they're unable to do that. So be aware of that difficulty patients may have. Okay, the lower airways go from the trachea down to the alveoli, down into the lung. So consist of the main bronchi, and if you'll look at, let's see, this consists of this. Now we're kind of talking about this picture here. So we're going from the thyroid cartilage, down in here, to the down to the, whoops, sorry, bronchi. I can't point in reverse. The main stem bronchi, the right is shorter and more vertical, so there's a greater aspiration risk in the right lung. The left bronchi are long and more horizontal, and the bronchi separate into 3 segments on the right and match up with the 3 lung lobes that are on the right. The right lung is larger than the left, and there are 2 segments on the left that match up with the 2 lobes on the left. And then there are more divisions that go out to the alveoli. And the alveoli is just the medical term for the air sacs. Okay, let me get this back in order. And I think of the bronchi and out to the alveoli as they look a lot like if you held a piece of broccoli upside down. Looks a lot like that. And if you want to think of that for yourself, visualize it that way, or in describing it to your patients, that's what their inside of their lungs look like. Okay, now on to the physiology. This slide here kind of makes me think of just giving you some facts for if you're ever on Jeopardy, because they're interesting to know, but it really doesn't tie in with the next slide and build up to anything. The respiratory center is in the pons and medulla, so it's in the, you've got the cerebral cortex, and then you've got the midbrain. So the pons and medulla is in the midbrain. It's a very basic, necessary function for life. And if your respiratory center, is not working, it's over. When you talk about somebody who's been in a severe accident, and this is the very basic part of your brain that has to work. You can have no brain wave, and your respiratory center can still work. So your respiratory center supports life, but there can be nothing else going on. So the respiratory center is a very basic, early, primordial part of your brain. The chemoreceptors that are in the medulla and the carotid bodies are sensitive to changes in carbon dioxide. And if there's an increase in carbon dioxide, you start to breathe faster to get more oxygen into the blood. There are two reflexes that they wanted you to know about, and here's where I talk about just Jeopardy questions. The coughing reflex, to keep stuff out of your lungs, to keep you from aspirating, and the Herring-Brewer reflex. Those are 2 doctors that are 2 researchers who named this reflex, and I looked it up to get more information about it, to see why we should know about it, but it's just kind of an interesting thing. It's the delay in the next inspiration following a large breath. So all it is when you take a deep breath, it's just a few seconds before you need to take another breath. And it's just a reflex to prevent overinflation of your lungs. So very interesting. But then the mechanical factors in breathing. Moving on to that. Lung compliance is the ease with which the lungs are inflated. So if you've ever blown up one of those skinny balloons, they are not very compliant. It's just so hard to blow up. They are non-compliant. And then you've had other balloons that they're cheap or they're easy to blow up. They are compliant. And elastic recoil is dependent, so that's the ease with which it snaps back. Is dependent on surfactant, and we've all heard of surfactant, but I thought let's look at that a little bit more. Surfactant is a slippery substance that the body produces, which reduces the surface tension of fluid in the lungs and helps make the small air sacs in the lungs. Those are the alveoli, the little air sacs at the end of the bronchioles, more stable, and keeps the alveoli from collapsing when an individual exhales. So if there's not enough surfactant, those little air sacs will collapse. And surfactant is a problem in babies that are born prematurely. They don't have enough surfactant, so those alveoli collapse, and they have respiratory failure. They can't get enough oxygen because the alveoli have a lot of capillaries in them, and that's where oxygen and carbon dioxide exchange takes place. So if there's not if there's not surfactant to keep those alveoli from collapsing, oxygen can't get into the alveoli, can't be exchanged, can't go into the bloodstream, and can't keep the brain and the body going. So that's the problem with preemies. A lot of times is the surfactant. If their system isn't well enough developed, and the surfactant isn't, their system isn't well enough developed, and there isn't enough surfactant to keep the respiratory system functioning. Airway resistance, that bullet there, I thought it was interesting that the upper airways are responsible for 45% of the resistance and decreases with inspiration due to widening of the airways. Well, so remember we talked about that the upper airways is just the nose and the is the nose and the pharynx and larynx, and that provides 45% of the resistance. Yet when we work with our patients, we're listening, auscultating their lungs, and we're trying to get them to cough to clear their secretions that are in their lungs. We're dealing with the resistance down here. We don't usually have problems or work with them when they're having resistance or with the airway resistance here. So I just thought, wow, if naturally, by natural physiology, most of the resistance is in the upper airways, and there, by disease, smoking, fibrosis, whatever has happened, they now have resistance in the lower airways. That is significant. And how difficult. So now what has the resistance increased to if breathing has become that difficult? So we're adding on to the 45% resistance here. Now what's the resistance if they have disease in their lower airways? So that must be significant. What now is the resistance? 60%, 70%? So how difficult is it to breathe now? Okay, mechanical factors in breathing. I did a lot of reading to try to make this slide meaningful to us as therapists. The ventilation perfusion matching. Ventilation means air moving into the lungs, so that's the air that reaches the alveoli. Perfusion is the blood that reaches the alveoli, so that's the blood flow of pulmonary circulation that's available for gas exchange. Ideally, the oxygen that's provided by ventilation is enough to fully saturate the blood. There are diseases that affect the ventilation perfusion match, like obstructive lung diseases, COPD, emphysema, bronchitis, asthma, pulmonary vascular diseases like pulmonary embolus, cor pulmonale, which is an enlargement of the right ventricle due to diseases of the lungs or the pulmonary blood vessels. Hypertension, pulmonary edema, and pulmonary edema is what it sounds like. Pulmonary is the lungs, edema is water, so it's water in the alveoli. I'm sorry, pulmonary hypertension. So it's elevated blood pressure in the pulmonary arteries. And parenchymal lung diseases, so it's diseases of the tissues of the lungs. So those are diseases that can affect ventilation perfusion match. So other diseases that can affect ventilation perfusion match. So let's say somebody with a kyphosis, and so this where a part of their lung is not getting ventilated because they're so bent over that part of their lung doesn't expand. So they're having a ventilation perfusion mismatch. There are areas of their lung that will have low carbon dioxide or high oxygen. What about patients with Guillain-Barré or Lou Gehrig's disease or a high cervical spine injury? Polymyositis, I already said kyphoscoliosis. That going on to the next slide. This kind of expands on that same idea. Changes in ventilation can be due to uneven compliance. I found a source that said the alveoli in the lower lobes the tissue is more compliant, so it expands easier. So the alveoli that are up here in the upper lobes are stiffer. They don't expand as much as the alveoli in the lower lobes, so they can't grab as much oxygen. So I'm going off on tangents here. So think of what that means. Are people that breathe just with their upper chest and they don't expand their lower chest. They're already at a disadvantage for picking up oxygen because that alveoli is not as compliant and doesn't expand as much, so there's not as much surface area for oxygen to grab onto and perfuse into. So all the more reason for us to try to get people to expand in their lower chest. Now, where was I going with that? But so there can be uneven compliance. There can be uneven airway resistance due to mucus in certain parts of their lobes in different areas of their lung, and uneven expansion of their lungs due to gravity. Ventilation is favored in the lower lung areas, but gravity does limit expansion, as does their lying posture and the resistance of their bed. If they've got a hard bed and they're laying on their right side, that lobe is not going to expand as much. Okay, so just things to consider about their ability to ventilate their lung and their ability of the blood to pick up that oxygen. Make sure that I've talked about all that I want to. Oh, and then thinking about what can we do if they've had postural changes, bony postural changes, as well as neuromuscular in their chair, how it impacts positioning in their wheelchair. So they've got the kyphoscoliosis, so they've had the stroke and they're leaning over to the side. Not only does it look bad, we need to get them in there, really work on their positioning with that lateral support or that wedge or the Therafin bolsters on each side to correct their posture so that there can be that normal expansion of their lobes on either side, so that there's not that ventilation perfusion mismatch during their respiration, so they can expand the lobes on all sides as much as they can. Okay, catch up with myself. The non-uniform perfusion can be due to gravity. Hydrostatic pressure has a significant effect on perfusion and reflects the effect gravity has on blood flow. Always favors blood flow to the lower lung fields, not the lower lobes, but the lower lung in terms of gravity. So if you're standing, yes, we're talking about the lower lung fields, but if they're laying on their back, we're talking about the posterior lung fields. If they're laying on their right side, we're talking about the right lobes. If they're laying on their left side, we're talking about the left lobes. If they're laying on their stomach, we're talking about the anterior lung fields. You hear what I'm saying? So the main factor in creating non-uniform perfusion is gravity. So I talked to the director of the respiratory program at Bellarmine, and she said basically, because I was thinking, okay, how does this apply to me? And basically, when we're putting a patient back to bed who has pneumonia or who has had a stroke, we want to put the good lung down. We want to position them. Now, this is, of course, you have to consider pressure ulcers. Can't always put them in the same position, but you want to position them with the good lung down in general. Okay. Arterial, the slide that is titled Arterial Blood Gas Normal Values. What the takeaway on this slide that I wanted to get at was, in general, we can say that the partial pressure of oxygen should be around 100. The partial pressure of carbon dioxide should be around 40. And these values are critical in regulating the breathing levels and maintaining the pH, or so they're acid-base levels. And if those are off, it can cause respiratory acidosis, respiratory alkalosis. High pressure, partial pressure of oxygen and low partial pressure of carbon dioxide is a finding associated with pulmonary embolism, where blood circulation is impaired by a blood clot or an air bubble. Ventilation is wasted so no blood gets oxygenated. It can also be seen in somebody with COPD. COPD destroys alveoli and leads to large dead air spaces and a loss of capillaries in the lungs. The large air spaces mean that some of the air breathed in gets nowhere close to a cell. So the loss of capillaries means that some areas of the lung aren't getting much blood while others are getting plenty. Now, low partial pressure oxygen and high partial pressure carbon dioxide are seen in patients with chronic bronchitis and asthma. So that kind of makes sense. Somebody with COPD, like we said, they have high partial pressure oxygen because they can breathe in. But their problem is they've got the barrel chest, remember. They can get the oxygen in, but they have trouble getting it out. Those are the ones who we teach to purse slip breathe, purse slip exhalation, because they have trouble. They don't have recoil. They have trouble getting the air out. They've got all this dead air space. So they may have high partial pressure oxygen, low partial pressure carbon dioxide. They have high ventilation, I'm sorry, I still get confused. They have high ventilation, low perfusion, because they have these dead air spaces in their lung where there are no capillaries. The opposite, people with chronic bronchitis and asthma, they have trouble getting air in because they have obstruction with mucus and plugged airways. So they have low ventilation. Nothing's wrong with their perfusion. Once the air could get there, they could circulate it. They just can't get the air in. So they have low partial pressure oxygen and high carbon dioxide levels. Okay. So just thought when we have those kind of patients, you would could understand their if reading their labs, you would understand what's going on there. Excuse me, I'll wipe my nose here. Okay. Pulmonary function tests. Okay. Again, remember, tidal volume is resting breathing. That's just resting breathing, the in and out, the inspire and exhale. That is tidal volume, and that normally is about 500 milliliters in a healthy young adult. Inspiratory reserve volume is about 3,000 milliliters. So that when you take a breath in, that's inspiratory reserve volume. And the point I wanted to make about that is that, remember, our people with COPD, they are operating in their inspiratory reserve volume all the time, not just for restful breathing. They're having to use their inspiratory reserve volume at rest, much less when we're asking them, can you walk a little bit further? Can you reach a little bit higher? Can you brush, can you brush the back of your head? Everything is an effort for them. Expiratory reserve volume is the amount of air a person can exhale after normal resting exhalation. And residual volume is the combination, well, that this gets confusing, and I don't think that it's necessary. I can show you a chart that what this slide is telling you. It says, let's move this. It's telling you that a combination of two or more volumes is a capacity, and I'm just going to tell you this so that it's not confusing. I thought that it was a misprint, that there was a grammar error, but a volume is in respiratory language, a volume and a capacity. Those are measures. And so let's see if I can put this up here. Yeah, pretty good. Okay, if a residual volume, pretty good. Let's see. Okay, well, I can't get it all. Maybe if I pull it back a little bit. There we go. There we go. So here are all the vital, what do you call, pulmonary function test values. So you see that tidal volume plus inspiratory reserve volume is inspiratory capacity. Then expiratory reserve volume plus residual volume equals functional residual capacity. Okay. Then inspiratory capacity plus functional residual capacity equals your vital capacity plus your residual volume. And then those two, a capacity plus a volume equals the total lung capacity. And what it's telling you here is a combination of two or more lung volumes equals a capacity. So a capacity is a larger measure than a volume is. Now, I know this is, or if it's not Greek to you, you are a better person than I am, because it is, whoops, it's still Greek to me. Remember, for a later unit that we're going to talk about, vital capacity there is what we're looking at when we do incentive spirometry. So see over here, vital capacity, that is what we're looking at an impairment of when we work with, gosh, I don't know why I can't hold this still, when we are doing incentive spirometry. So I will keep this little, you will see this little slide again, this little chart again, when we do the section on vital capacity, on incentive spirometry. But I mostly just showed that to you. You don't have to memorize that for our purposes working as therapists, but just so you'll understand that slide, because when I read that slide, I thought, I have no idea what they're talking about here. But residual volume increases with obstructive lung diseases such as emphysema. It's just a volume you can't access, except like when I remember my husband saying his brother hit him in the solar plexus and just you're winded, it knocks you out because it just knocks the wind out of you. Okay, pulmonary function tests. Then this page here, those are the values that I just showed you on a chart, how they relate to each other. This is just a reference for you. We rarely get those lab values from the hospital. If we do, you can refer to this chart to get the definitions and how they relate to your patient. This bottom value, the vital capacity, I was very interested in to see how we could use this. It says if 60%, if their vital capacity is less than 60%, they will have an ineffective cough, as there is not enough volume to clear secretions. And I thought, okay, we've got an objective value that we can use in our goals. So when I was talking to the director of the respiratory program at Bellarmine, I asked her 60% of what? And she said it's 60% of the predicted vital capacity. And how do we get that? It's not something that we can calculate. It's something that is calculated by the test that they take in the hospital. So again, it's something we're reliant on on the tester, on the machine from the hospital for. So I wish we could have this value, but we don't. If you happen to be lucky enough to have a patient who has had pulmonary function tests and has this value, it will be. She said it will be stated on there that their 60% of PVC equals da da da, and you can use that value in your documentation for effective cough. Okay, the 4 major lung capacities are listed there: functional residual capacity, vital capacity, inspiratory capacity, and total lung capacity. The points I wanted to make about that were referred. Just keep this chart and know that you have it available if you need to refer to it. Know what the values are. Vital capacity, normal is about 4,500 milliliters. If you have ever had your patient use an incentive spirometer, you'll know that our patient's vital capacity is usually nowhere near this 4,500 milliliters. It may be 200, 400 milliliters instead of 4,500. So it just gives you some idea of the level of disability that our patients have, and should impress upon you the need that our patients have for pulmonary muscle strengthening. It's really an area that we have detached ourselves from, and we need to get back in, because we're wanting our patients to walk, to reach, to use their upper extremities, and they can't even breathe. So this is an area that that PTs used to do all the time: percussion, postural drainage, pulmonary muscle strengthening, be very involved in. Then respiratory therapists came in, took that over. Then Medicare stopped paying for respiratory therapists, and PT never picked it back up. And it has shown in the ability of our patients to fully recover, because we're leaving out a big piece of a foundational piece of function. If you can't breathe, you can't do anything. I mean, that should go without saying. If you can't, it's like, it should go without saying, if you can't take a breath, if you can't maintain your respiratory status, you can't be expected to get dressed or walk or go up steps or to progress with your therapy. We've got to strengthen these postural muscles, which are also respiratory muscles. So enough of that soapbox, but it's got to stay at the base of, they can't speak, they can't have volume for their speech, they can't have the breath support for swallowing and eating. It's got to start there. It's got to start there. So this strengthening of the trapezius, of the rhomboids, of the latissimus, of the abdominals, of the diaphragm, we've got to get back to this before we worry about the biceps and the quads and walking 150 feet and 120 degrees of shoulder flexion. That doesn't matter if they don't have the breath support and if they don't have the breath support. Normal aging in relation to the mechanics of breathing. There is a 40% decrease in vital capacity with aging, which is what I was just getting on a rant about a minute ago. The respiratory muscles are less elastic. The abdominal muscles lose tone and strength, so the diaphragm drops. And if it can't rebound to its resting position, it can't have as great of an effect on pushing down on the abdominal muscles. There's a decrease in chest wall compliance, so that there's due to a decrease in elastin in the lungs and the chest wall. There's stiffer soft tissues. There's stiffening of the joints and the rib cage, and there's increased kyphosis. So there's not that recoil that allows the chest wall to come back to the beginning position so that you can take a deep breath the next time. The respiratory gas exchange surface decreases due to thinning of the alveolar walls and enlargement of the ducts in the alveolar and the alveoli. There's a decrease in blood flow secondary to the decrease in the number of pulmonary capillaries. So that, I mean, that's going on in other parts of the body too. There's a decrease in the number of blood vessels, and the residual volume doubles due to decreased. It says increased. You need to change that to decreased due to decreased lung compliance and loss of surfactant. Remember, surfactant is what keeps the alveoli from collapsing. And so there's a loss of surfactant that results in decreases in elastic recoil of the lung. So it's indicative of less efficient breathing mechanisms. Okay, the bed rest in relation to the mechanics of breathing. The ventilatory volume at rest and during functional activity declines by as much as 50% within the first week of bed rest. There's a decrease in the stroke volume, so now we're talking about cardiac, but they're just slipping it in here. Decrease in stroke volume by approximately 10% within the first week and decreases to approximately 10% per week thereafter. So bed rest is just devastating to people. We've got to get them up and moving, even if that getting them up and moving is as simple as getting them up on the side of the bed with their legs dangling, or getting them over into a cardiac chair or a recliner with their legs raised. We need to get them out of supine, get their legs down. Now that doesn't mean just flippantly putting them over in a chair and saying we got to get them up. You got to check their vitals, make sure that their heart rate is, going back to the things we talked about in the first or second module, checking their heart rate, making sure that it's responding appropriately, their blood pressure, their O2 sats, their Borg rate, looking at their color, are they breaking out in a sweat, checking all those things that immediately at 3 minutes, at 5 minutes, at 6 minutes, at 15 minutes, a half an hour, 45 minutes, and making sure that their physiological response is appropriate. And then when that is stable, then turn it over to nursing and progressing their therapy accordingly. So if now they're okay sitting, turn that part over to nursing, and you come back to do more progressive exercises. Turn over the stable part to nursing. Or do you need to break up their therapy into different sessions because they can't tolerate so much at one time? Instead of a 72-minute session, you can only do, initially maybe you can only do 10 minutes at a time. And I know you've heard that going in one ear and out the other. But really, if they're that debilitated, and we are getting more debilitated patients, do you need to go back and do little bits like that at a time on our medically complex patients? Remember, that's what we're talking about in this training.